It's the top of the hour, so I'm Jill Holt. Good afternoon if you're in Montana or Wyoming, and good morning if you're in Hawaii or in Alaska. I work for the nursing home team with Mountain Pacific, and it's just a real pleasure to have everybody joining us today. Today is the first of a series that we're conducting. We will have a session each quarter. Today, you will be hearing about updates to the 5-star rating system and publicly reported quality measures. And we will be hearing from Jennifer LaBay. Just a few housekeeping items. If everyone would remember to keep your microphones on mute unless you're speaking. And because this is a meeting format, you are able to unmute and ask questions of Jennifer and to speak. We will have a evaluation link at the end of the presentation that you'll need to complete so that we can then issue continuing education units for this session. I would like to, at the next point of my conversation here, I'd like to introduce Jennifer. Jennifer LaBay is an RN. She's RN RAC/MT, RAC/MTA, CRC, is the MDS policy consultant for Triad Healthcare in Providence, Rhode Island. She is also an AAPACN training partner and AANAC master teacher as an independent contractor with JLB MDS Consulting in Pawtucket, Rhode Island. She has been involved in the RAI process since 1997 and has been in the long-term care industry since 1991, serving in a variety of capacities, including CNA, charge nurse, MDS coordinator, and regional corporate clinical reimbursement specialist. Jennifer has been a master teacher for AANAC's RAC-CT program since July 2011, and AANAC's retired Medicare University program since October of 2012, and AANAC's new advanced RAC-CTA since 2019. Jennifer is a certified risk coder through the American Academy of Professional Coders. Jennifer has considerable expertise in the MDS, RAI, PPS, ICD-10, including the clinical and financial aspects. She has a knack for making her seminars an enjoyable learning experience and readily makes herself available to all attendees of her programs for any follow-up questions that may arise long after the seminar is complete. And as you're hearing from Jennifer today, if you would be thinking about future topics that you would like to see Jennifer present in the next series, please just enter that into the chat box. And so now, Jennifer, the floor is yours, and thank you.
Well, thank you very much, Jill, and everybody at Mountain Pacific Quality Health. I'm so happy to be available to you again this year. We did some programs last year, and I'm very happy to be back with you all this year to hopefully dive into some more clearing of the muck, if you will. We got a lot of stuff going on in our area, SNF and quality measures and 5-star and PDPM and ICD-10 and all sorts of acronyms. So hopefully I will assist everybody to clear through some of that muck. And we'll try to start to do that today. As Jill said, I am available for questions, so just unmute yourself, or you could throw a question into the chat. There's also a raise hand feature in the chat that the moderators will be keeping an eye on, and I also can see as well. It's nice to be able to reach everybody across the country. I've been doing a lot of Zoom trainings, and it's actually been going quite nicely. I've worked with a lot of folks from Montana and Wyoming and Hawaii and Alaska in some of my classes. So it's nice to be able to reach out to you folks from little old Rhode Island out here on the East Coast. So let's dive into what we're talking about. We've got our 5-star and publicly reported quality measure updates. There's a lot to cram in into one little hour. So I'm just going to kind of give a broad view. And if you've been in any of my trainings before, you'll know I like to give references. I like to show where to get the information. So it's not just me spewing out the information, but I'm going to give you some websites and references. The slides will be made available to you after. I apologize, I'm a procrastinator. I was putting the final icing on the slides as we were prepping this video. So they are ready in Jill's hot little hands to post and share with you all. I'm always available for questions afterwards if anything comes up. My contact information will be at the end of the slide deck, and certainly you can reach out to anyone at Mountain Pacific and they know how to get that information to me so I can answer your questions. So the 5-star user's guide was updated in January, and there were some changes. So you may have noticed those changes and maybe wondered what the heck. So hopefully we can kind of go through some of those changes, talk about some of the things that have come up because of the public health emergency, how it relates to the 5-star, how it relates to the reporting publicly, the SNF QRP reporting, and then we'll take a look at some of those measures that are on the Care Compare website. So that is something that is, well, we're marching, we're halfway through April here, 3/4 through April. So this year is marching along quite fast. But in December, they changed where the publicly reported quality measures and 5-star ratings are. So we'll take a look at that as well. So as I said, your 5-star technical users guide, make sure you have the most up-to-date one. A few slides in, I do have some links for you to where do you go to get the technical specs, where can you download this, where do you find the information. Like I said, I always like to make sure you have some sort of a reference. So this is what it should look like. And there were some changes. So as we know, the health inspection rating, or maybe we don't know if we're not as familiar with how we calculate the 5-star, but the health inspection rating is one of the 3 domains that contributes to the overall star rating. And the health inspection rating is the starting point for that overall rating. So this is really the most important one, because this is going to be your jumping off point. You can improve or go down a little bit with the other 2 measures, staffing and quality measures, but this is your starting point. So this is calculated by the most recent 3 standard surveys and the past 3 years of complaint surveys. And the most recent surveys, either your standard or the past or earliest 12 months, most recent 12 months of complaint surveys, weigh the most, and then the next cycle doesn't weigh quite as much, and then the third cycle weighs the least. So with this particular domain, we're looking to have low points assigned, because the lower the points assigned, the higher the star rating. So with the different deficiencies and different items that will calculate this health inspection rating, that will keep adding points. So basically, the more deficiencies, the more higher scope and severity, the more points will be assigned, the lower the star rating. Additional points are assigned for substandard care, repeat deficiencies, and the number of revisits after the first revisit. And as I said, the higher the points, the lower the star. So due to the public health emergency, obviously there was some concerns about how this is going to impact the health inspection rating. So last year, the health inspection rating was held constant. They froze that star rating with any surveys that occurred after March 3rd, 2020. So whatever your star rating was for health inspection as of that point, it held constant. Beginning with the January 2021 refresh, CMS resumed calculating the health inspection rating domain and began to use the results from the surveys that occurred after March 3rd of 2020. So that means if you had any survey, and a big chunk of those surveys that were happening, because there was a hold on the survey process as well, were infection control surveys, maybe complaint surveys. So those focused infection control surveys, as well as the complaint surveys, and if you did happen to slip a standard survey in there after they resumed those later in the year, those are now going to be used to recalculate your star rating. So depending on how you did in those surveys, you may have seen a big jump, either to the good or to the bad, from that refresh in January. So if you had a really good survey prior to March 3rd of last year, and then had some not so great surveys after March 3rd, you were okay for a while until we hit the January refresh. And then those maybe not so good surveys would have hit and affected your star rating. So they've, like I said, added those focused infection control surveys as part of the calculation, similarly calculated to how the complaint surveys were looking at years and months. So the first 12 to 24 months, 23 months, 24 months to 36 months in the first 12 months. That's how it's going in 12-month increments. So they're looking similar to that and the weighting system for that. Let's see, I have a question in the chat. We've not had a survey since 3/19. Is that survey used if there has not been a survey in the last 12 months? Yes, so it's not going by an annual review for your standard surveys. It's just looking back to your last 3 standard surveys. So if your state is behind and your last standard survey was March of 2019, which was pretty behind, then yeah, that's going to be the survey that's used as your most recent survey. And then that's called cycle 1. And then the survey that was done before that is cycle 2, and the survey that's before that is cycle 3. So until you have your next standard survey, those are going to be what is used. So it doesn't go by calendar year. The complaint surveys and the infection control surveys are looking at months and years from those calculations of the star rating. So these changes also resulted in an update to the Special Focus Facility Program, including updates to the Special Focus Facility candidates. So the Special Focus Facility Program is for those facilities in the country that aren't doing so great, maybe had some bad survey outcomes and are now on the watch list by the government. And they're, you would know if you were a special focus facility, you would have had some bad surveys, some substandard care, maybe, some abuse. But this is not a secret. You can search on cms.gov, do a search for special focus facilities, and it will bring up the information of everything in the country, folks that are now candidates. Maybe they're looking at them to see if they maybe should go on the special focus facility list, or folks that are on facilities that are on the focus facility list already and haven't improved, those that are on the list and have improved. I did a quick look. Alaska looks really good. No Alaska homes are on any of the special focus facility lists. There's 1 on the no improved list in Hawaii, 2 on the improved list, 1 in Montana and 1 in Wyoming, and then 15 in your group on the candidate list. So just because you're on the candidate list doesn't necessarily mean you're going to get on the special focus facility list, but those are 5 each in Hawaii, Montana, and Wyoming. So you can go to this website, download the information, see who's on it, say, oh, which of my neighbor homes are potentially a special focus facility, or who do I maybe, want to be concerned about going to get a job at because there may be some more scrutiny. The issue with being a special focus facility is your rating is not going to be shown. So that's not going to be shown. And then also if you have an abuse icon, so the abuse icon is going to be for facilities who have recently been cited for resident harm or potential harm for abuse or neglect. Now, if you didn't have any issues with abuse up until March 3rd of 2020, you would not have that abuse icon. But if you had a complaint survey or a standard survey since that then would have triggered this abuse icon normally, with that January 2021 refresh, you may now have that abuse icon showing up on your facility. And that's what it looks like. Now this is, I'm not telling tales out of school. This is public. So this is one of the homes in my state that has the abuse icon. That's what it looks like when you search for it publicly on Care Compare. You've got that little red hand. They are capped at a star rating. They can't go any higher than a 2-star rating when you have that abuse icon. So if you had the abuse icon and it has since resolved, with that refresh, you may have seen that go away. And then that may have upped your health inspection rating as well. Let's see another item in the chat. So how does a facility get off the special focus facility list? Basically, you just have to provide better care and that your revisits show that you're improving, that you are following what's in your plan of correction. Some facilities may have some sort of like a state monitor assigned for a certain number of hours. I know that this home in particular that I have on the slide, they have like an assigned monitor who kind of oversees the process, and then they have revisits. And then depending on how good they do, and if they've shown improvement, and if they continue to show improvement, then they can graduate. How long are you capped at that 2-star if you have the abuse icon? Until you no longer have that abuse icon. So once you've gone a certain amount of time and your most recent survey no longer shows that abuse, or your most recent information no longer has that, then it will go away. Question, does the abuse icon get triggered from state survey findings or from when the facility self-reports? I believe so. The abuse icon, I'm going to have to look that up specifically to give you some more information. But that is generally triggered by survey issues. So a complaint survey, if you self-report and they come out, investigate, and give you a deficiency and tag you on one of those abuse or harm or potential harm for abuse or neglect, then you'll get that abuse icon. The next domain that was updated with this January refresh and before was the staffing domain. So as a reminder, staffing is calculated based on the reported RN and total nursing hours reported in a quarter, and are further calculated using MDS census data and MDS acuity. So this is the reason why, MDS, I've said it before, I've been accused of being an MDS diva because I think the world revolves around MDS. Well, it kind of does, because there's so many things that impact our SNF overall, whether it be payment, quality, survey, the 5-star rating for quality measures, also the staffing domain. So if you don't have accurate assessments and your acuity doesn't accurately reflect the type of residents you're actually caring for, your staffing rating may be skewed by what that calculation is, because it looks at acuity based on RUGS 4. Yes, we're in PDPM, but it does still calculate on RUGS 4 for acuity. There has been no word from CMS as to whether they're going to convert the acuity calculation to PDPM. They actually had just recently converted from RUG 3 to RUG 4 right before PDPM started, so it could be a while. But it's looking at the MDS acuity, and then their calculation based on the STRIVE study that they did years ago when they were determining RUG weights, that helped to determine what staffing level is needed based on the acuity of the residents in your building on each day for that quarter. Also, the census is calculated based on the MDS information. So the MDS data, whatever assessments are submitted into that federal repository, that's how they calculate your census for staffing. They will look at all of the assessments that are in the KEYS ASAP system that have been submitted and say, okay, well, these people haven't had a discharge or a death, so they are considered to be active residents. But if you, for whatever reason, have kind of been delayed in completing those discharge or death in facility tracking records, there's a 150-day gap where your census may look much higher than it is. So this has been a little tricky with the public health emergency and the waivers, in that the timeliness of the MDSs, that has been waived. That waiver is actually expiring May 10th. But it was part of that calculation was looking at census. So if you were not submitting assessments, your census for staffing may have looked a lot larger than what your actual census was. So that's another reason why MDS completion, MDS accuracy is important, because of this calculation for the staffing. Once somebody hasn't had an assessment done for 150 days, then they presume that they're not there. So then they will drop off of the census, but it's that 150 days in between. That's a lot of days where your census may look off. Prior to the public health emergency, if the payroll-based journal staffing information was not submitted timely, or if the RN staffing requirements were not met, the facility would be capped at a 1-star rating for that quarter, which would then bring your overall rating down, because if you have a staffing rating of 1 star, that's going to bring your overall rating down by a star. The public health emergency waivers did put the payroll-based journal submission on hold at the beginning of the public health emergency, but that was terminated in June of 2020, and the reporting resumed with the August 14th update of 2020. But they did give us a little bit of leeway. Instead of showing us as a 1-star, if you did not submit with that August update, it would show the rating as not available. So even though we were no longer exempt from reporting, the government did give us a little bit of a break in stating that the information was just not reported. Beginning with the January 2021 refresh, facilities that didn't report their staffing for that November 14th, 2020, which looking back, you can see on that slide, that would be the Q3 of 2020 information. If they did not submit at that time, no longer is it going to be called no reported, it was going to be capped at that 1 star again. So they have, completely gone back to the normal calculation of staffing. And it's, so for that November, you would also get that not available, but with the April refresh, the April 2021 refresh, they've stopped that. So if you didn't submit as of February 14th, of this past year, you were going to be capped at a 1 star for your staffing rating. So that has gotten a little tricky, as I said, because although we have to report the PBJ, we had to report that fourth quarter information because of that MDS completion waiver. That may have skewed your staffing as well, because if you haven't completed those discharge assessments, it may look like you have a lot more assessments or a lot more residents in your building for that quarter, just because, the timeliness waiver didn't force us to complete those assessments. So that could be a reason why your staffing may look a little bit off because of the public health emergency. And finally, the quality measure rating changes. The quarterly updates of most of the quality measures posted on Care Compare, used in the 5-star rating, resumed with that 2021 January refresh. And for that January 2021 update, CMS used data for July 2019 through June 2020 for all of the measures that were updated. There were 2 quality measures that are a part of the SNF QRP, which is the pressure ulcer, pressure injuries that are new or worsened, and the rate of successful return to home and community that were not updated with that January 2021 update. So as I said, there was an update to the place where the public reporting goes, and that is Care Compare. It used to be Nursing Home Compare. The Nursing Home Compare website was ended, and it's now everything is in the Care Compare website. And a lot of the information that was in Nursing Home Compare, it just all moved over to Care Compare. So there really was no change other than all of the Compare websites are in one place. So when you go to that Care Compare website, you can look at other providers, not just nursing homes. There was a tip sheet that was put out related to the SNF QRP quality measures related to the COVID-19 public health emergency. And this tip sheet came out last year. You know, a lot of this stuff has already gone past, but just, you know, so we can have a little background, there were some temporary exceptions to the reporting for the SNF QRP. Q4 of 2019 was optional. Any data that was reported would be used towards the calculation for SNF QRP, but it wasn't going to be held against you if you didn't report it. And then there was accepted reporting for Q1 and Q2 of 2020. So any data that was submitted, even if you were submitting data, now I think a lot of facilities were still submitting PPS assessments because you still needed to get paid. You can't get paid by Medicare unless you have an assessment completed and a PDPM score completed. So I think a lot of facilities, even when they were in a pickle of staffing and COVID crisis, they were still completing those assessments, which are the assessments that calculate towards the SNF QRP quality measure. But because of the public health emergency, the government said, okay, even if you submit stuff, we're not going to use that data from Q1 and Q2, which goes from January 1st to June 30th of 2020. So that data was not used for the SNF QRP calculation. It also wasn't used, that same 2 quarters was not used for any calculation for the value-based purchasing, which is the claims-based 30-day all-cause readmission measure for that same time frame. Those waivers that accepted those 2 quarters ended June of last year, and the data was frozen following the 2020 refresh in October of 2020. So this is the summary of the data refreshes that are going to be happening, and that information for the SNF QRP is going to be held constant until the SNF Care Compare site refreshes in January of next year. Then the refreshes will return to normal by April of 2022. So there's a freeze on your SNF QRP data for the January, April, July, and October refreshes for this year. The public reporting will resume in January, and then we'll go back to normal. So because of this, there's 2 quarters of missing information. That missing information may impact how the SNF QRP quality measures are calculated, because in order to calculate that, you have to have a completed stay. So a type 1 stay or a type 2 stay, where you have a 5-day PPS assessment, and then either PPS discharge or assessment or a death in facility assessment. That's how the quality reporting program measures are calculated, is by having a complete stay. It's going by stays, not assessments. So if there was a 5-day assessment completed in the time that was accepted, and then a discharge assessment completed afterwards, CMS isn't going to use that information because they don't have the data to create a full stay, a completed stay. So they're aware of that. They're doing calculations on their end, and they'll look into future rulemaking to see how are they going to do that calculation. But in the meantime, all of the SNF QRP data that is publicly reported is old. It's all going to be from back in 2019. So if you did really well and your quality measures, SNF QRP quality measures were good at that time, then that's going to hold constant on the publicly reported Care Compare until that normal refresh occurs in 22. So, and opposite, if you didn't do so great in your quality reporting program up until that point, you're going to be held with that until that refresh and public reporting restarts. So how does this freeze affect your data, or how did it affect your data? So the provider preview reports, the purpose of those reports is to give the providers the opportunity to preview their MDS quality measure results that prior to the display on Care Compare. Subsequent to the 2020 October refresh, CMS was not going to issue provider reports for those refreshes that continue to contain constant data. So if the data hasn't changed, they're not going to send out those provider preview reports because nothing has changed until they start that public report again. The review and correct report, the purpose of this report was for the providers to have access to the quality measure data prior to that data correction deadline for public reporting. And it will include data from the most recent quarter that is open for data correction and the data from the previous 3 closed for data correction, which is the frozen data. There will be no data available to correct for Q1 or Q2. So that was on hold. So you didn't see that. That's why you may not have seen that last year. And then the quality measure reports. These reports will give you confidential feedback on your agency's performance. So you can run these at any time during your reporting period. It's going to be whatever you submitted, that's what you'll see. And you can see that information because that's not publicly reported. It's available to you and you can see it at any time. If you did submit data in Q1 and Q2, you can still see it because it was submitted and it was there. It's just not going to be publicly reported as part of that quality measure. So as I said, the data will return back to normal in April of 2022. So still another year from now before things look normal again. How about any submissions after the July 1st, 2020? So those first 2 quarters were accepted. We had to start submitting again with that data July 1st, 2020. How is that going to impact? And as I said, CMS is going to have to make an adjustment on their end when there's mismatched, no 5-day assessment to match with a discharge or death in facility assessment based on what was done in Q1 and Q2. So there would be an error. But they are not going to be including that data and any of the calculations that are on Care Compare. There also was a delay. There was supposed to be a new quality measure for transfer of health information, but that was put on hold because of the public health emergency. And this is going to be delayed for 2 fiscal years after the end of the public health emergency. The public health emergency was just extended again. So once that public health emergency is officially ended, then 2 fiscal years after that, then they will resume talks of putting this quality measure out. So this one's on hold for a while. So as I said, we've got a new publicly reported website. It's no longer Nursing Home Compare, it's Care Compare. This is what it looks like. The website is there for you to click on. So this is going to allow you not just to look at nursing homes in the area, but also hospitals, doctors, home health agencies. It's just basically making it easier for the public to go to one spot instead of having to search separate websites for each of these providers. And that's really all it did. It just moved the information into one area. For me, one flaw is the search feature. Under Nursing Home Compare, you used to search, be able to search a state to see all of the facilities in a state. But now you can only search via city or zip code and then a surrounding radius, not just the entire state, which me, as somebody who likes to advertise to folks in states, that was something that I miss. I don't know that other people are missing it, but I certainly miss it because I can't just see all of the nursing homes in a state very easily through this site anymore, which is unfortunate. So you're going to be looking at your location, your provider type. You can search by name of facility. You can filter by their rating, the distance from your location, any other ratings, number of certified beds, and it will show you the homes. And like I said, I'm not telling tales out of school. This is all public. So I just did a search in my area to see what it looks like. So it looks a little bit different than it did on Nursing Home Compare. Once you click on a facility, and this is all what the public is going to see, it's not a bad idea to go in and look at this and see what is out there. What does the public see, and what does it look like? How is it explained to the public? And that's kind of like what I'm going to just skim over, is what this looks like on the public side to help maybe us understand, putting these quality measures into layman's terms, to see why is it important to us and what does the public see as an issue. So when you click on the facility, it will give you the overall rating, your health inspection, your staffing, your quality of resident care. You can view the details, and then you can also see how does Medicare calculate this rating. And then that's going to slip you out into the CMS data website. That CMS data website is going to give you some background about how is this rating calculated, where should I go to, and how do I use this rating. So as you can see on the bottom, how should I use this nursing home star rating? This is how the government feels that it's being used and should be used, that you can use this guide to choose a nursing home or this nursing home checklist. Well, this guide is a 44-page guide that is supposed to be used by the public. I can actually just give you a quick share of that because I do have it up on my my site just so you can see it. There's a lot of different things. So this is the guide. Hopefully you can see that. But 44 pages of all the things that anybody who's prospectively looking at coming into a facility or bringing their loved one into a facility that they should look at. So that's what they're supposed to be reading. And then this is the checklist. So, you know, this could be the checklist that they should be using, 9 pages. Now, there's always been these guides and these checklists. I don't know that anyone has ever actually used that, but that's what they're there for, and that's what they're intended to be. Oh, I think I might have not had them on the right screen. Let me switch that over. So this is the checklist, 9 pages long of checklist, and then 44 pages long of guide. Hopefully you can see those now, but that's where you can get that. So that's right on Care Compare. So that's intended to be what they're using it for, like what the whole Care Compare website is supposed to be. Just hop back into the presentation. Hopefully you can see the presentation again. You can also look, so this is all on Care Compare. Learning more about quality of care. So these are the facility quality of resident care ratings, short stay quality of resident care rating. These are the actual facility ratings. And then the quality of resident care, again, you can click outside of that website, bring you to this data website, which gives you all of the background about what the different quality measures are and why they're important and why you as the consumer or why, you know, as the public, why they should be concerned about these different quality measures that are triggering, because you can see that. You can look and see which quality measures are an issue for the facility. All of this is publicly reported. And then it will also show you the dates. So this, and I don't know that the public is looking at this, but this shows you that the data collection period is old. So this information for your claims based is looking back to June of 2020. And it's old data in a lot of cases. And then your MDS related items are just looking at 2019. So the information there isn't that up to date, but I don't know that the public clicks around all of these items to see that that is the case. They may think that, oh, this is current, what's going on in the building right now. And we all know that it's not. The information is there for the public, but you got to click around to see it. And that was the case in Nursing Home Compare as well. I wish they had made it a little more transparent, that you don't have to click around to find things, that it was just very clearly here. This was based on this data at this time. So as I said, these are just the additional resources just to go back. Your 5-star technical spec, your quality measure manuals, your SNF QRP manual, your value-based purchasing information. We should already know this, certainly this would be a whole other day's presentation to go over all of this information and how they're calculating. If you joined us in last year's sessions, we did go over some of this. So we can certainly, address that in the future if there's other things that you'd like to focus more on in future presentations in the upcoming series. But just to kind of go over quickly what the different quality measures are that calculate for the 5-star rating. Again, this is straight off of the publicly reported Care Compare website. So this information is in the layman's terms. If you are the public looking to see what do these different quality measures mean, this is where you can find that information. Again, it's not as transparent. You have to click around to find it, but it is accessible to the public. And it's not as technical as maybe we would see it on our end and why it's important. So this is more showing why is this important to you, the public. So our percentage of our short stay residents who were rehospitalized after a nursing home admission. This is one of the claims-based quality measures. And it tells you, this will show you the percentage of the short stay residents who went to a nursing home from a hospital and then were readmitted to a hospital within 30 days for an unplanned stay. Planned readmissions aren't included. So it just gives the public a layman's term synopsis of what this means. What does this show you? Lower percentages are better. So if you're new with quality measures, it might be better for you to look at the Care Compare and starting to understand, why do these quality measures matter? What does this mean? What is it looking at? Because this could be a good starting point for you. Or if you have staff that's maybe not as familiar, or if you're trying to do some training with your staff, maybe, ancillary staff or, the CNA staff, that maybe it's not as technical in your explanation, and you can use this as that explanation. And then it tells you for each of these quality measures, what does this show you and why is this important? So this particular one, nursing homes help residents recover after being in the hospital and keep from going back to the hospital. Sometimes residents have to go back to the hospital. If nursing homes send many residents back to the hospital, it may be because the nursing homes aren't assessing or taking care of their residents well. So this is telling you, well, here's what could be happening and why this is an issue. The other claims-based short stay measure that affects the 5-star percent of short stay residents who have had an outpatient emergency department visit. What does this show you? This shows you the percentage of short stay residents who went into or came back to the nursing home from a hospital, got care in an emergency department within 30 days of going into the nursing home, and didn't need an inpatient or outpatient stay. Again, lower percentages are better. Why is this important to the public or for somebody who might be wanting to come into the facility? Emergency departments give necessary care for many residents of nursing homes. When nursing homes send many residents to the emergency room, it might be because the nursing homes aren't taking good care of their residents, so they need emergency treatment. This is all what the public is seeing. Is that really the true picture? Not necessarily. Does it say anything? Well, maybe the facilities, hospitals shouldn't send train wrecks to admit into our facility where we have to send them back because they should have never been discharged from the hospital in the first place. No, it doesn't say any of that stuff. It just gives you kind of like, well, they're not doing a good job. So if their number is high, that means they're going out. But one thing that we would be concerned about, yes, hallelujah, I see an amen in the chat. But one thing we may want to look at is our facility assessment. What are they going back out to the emergency department for? Is it because they're train wrecks coming in? Do we need to do a better job pre-admission screening to make sure that we're not accepting those train wrecks if possible? So maybe we need to look at our pre-admission process. And then looking at a facility assessment, what can we handle to prevent them from going out to the emergency department? Can we, do IVs? Can we do, more clinically extensive service so maybe they wouldn't have to go out to that emergency department visit? Now, certainly there's some things that we can't do in our facility that they may need to go to the emergency department for, transfusions, things like that. Obviously we can't do, but this is, the measure, how we would use it is, how can we prevent this from happening? Are these avoidable? Because all of the public is going to see is the numbers and the explanation. They're not going to dig and say, well, can you tell me more about this? No, they're going to go to the next home that they're reviewing and say, oh, these numbers are better. Everything looks pretty, but nobody, is really digging if I would like to know if somebody actually has had a family member come in with their guidebook and their 9-page questionnaire, I would love for you to email me, because I would love to hear that, because I have yet to hear one situation where that was actually used. The other short stay quality measure, we're now going to our MDS-based quality measures, our percentage of short stay residents that got antipsychotic medications for the first time. We don't need to go into, yeah, I didn't think so. I'm seeing some nopes in the chat. We don't have to go over each one of these. All of these are available to you on the Care Compare website, but it can help you see what is the public seeing related to this. I mean, we've always talked about it in theory, about all of the different items that are being affected and how the public sees it, but this actually tells them, this is what you need to look for. This is why it might be a concern. This is what they might be doing a bad job on. The other quality measure, percent of residents with pressure ulcers, pressure injuries that are new or worsened. So this was the changes in skin integrity post-acute care measure, which is a SNF QRP quality measure, which was updated in October of 2020, but again, gives you the public the background. Percentage of short stay residents who've improved in their ability to move around on their own. So this is looking at, it's got different terminology depending on whether you're looking in the quality measure manual or the 5-star manual. It's the percent of residents who've made improvements in function, but in the 5-star, it's this residents who've improved in their ability to move around on their own. So this is looking at, have they improved from that discharge, from the previous assessment to the discharge assessment, in self-performance of transfer, locomotion on unit, and walk-in corridor. So that's what that's looking at. And then I just included in the slide deck, I knew that we weren't going to have time to go over these, but maybe these are some things we can focus on in the future. Some of the additional publicly reported items that are out there, the flu and pneumonia vaccine, the publicly reported SNF QRP items, and it shows you why this is important and what you need to look for as a consumer. So we've got a lot of them here. Like I said, I had no intention of going over all of these. I just wanted to have it here so you had it as a reference point, because it's interesting to read it from the public's standpoint. And you're looking at like, well, wait a minute, this isn't telling the full picture. That's not right. That's not accurate. That's not true for now. You know, but like I said, public isn't necessarily looking at that. And we've got our other claims-based measures from SNF QRP. Our publicly reported value-based purchasing, that is listed on Care Compare as well. So that's 30-day all-cause readmission. And then we have our long stay quality measures that affect our 5-star rating. The hospitalizations per 1,000 long stay resident days. What does this show you? Why is this important? Number of emergency departments for the long stay, antipsychotic use, the falls with major injury, our high risk residents with pressure ulcers, our urinary tract infection, the catheter, folks whose ability to move independently has worsened, so the decline in locomotion on unit, percent of residents whose help with daily activities has increased, the ADL decline quality measure. Now this one publicly, I don't care for what this, what it says under what does this show you, because this is the quality measure that's looking at the late loss ADLs, bed mobility, transfer, toileting, and eating. But they throw in there bathing, grooming. That's not part of that. So I don't know why that's in there. I suppose you could say maybe, you know, dressing, bathing, grooming, and dressing. Maybe you could fit into toilet use because you have to provide toileting hygiene and adjusting the clothes. But I think that this is an incorrect display of what actually the quality measure is calculating. And then we've got some additional quality measures that are publicly reported, our restraints, our loss of bowel and bladder, weight loss, and symptoms of depression, and the use of anti-anxiety and hypnotic meds. There are some new proposed SNF QRP quality measures. If you've happened to take a look at the SNF proposed PPS final rule, which came out, there are 2 quality measures that they're looking to add. There is a public reporting, public comment period through June 7th. So that is the link to that Federal Register if you'd like to take a peruse. And this is looking at the COVID vaccination rates amongst healthcare personnel. This is a process measure not an outcome measure. So it's just saying, asking, did you report this? Like you currently have to report, but it's not mandatory. So that's just asking about the reporting of it, and then also looking at the healthcare associated infections requiring hospitalization. So take a look at that, and feel free to publicly comment on those items. There are many other things that are in there. So that is our presentation. Like I said, you know, it's just kind of it's hard to cram all of that into a 45-minute, but I wanted to give you the highlights, the hits of what those changes were and how it's going to affect. As you can see in the chat, if you're looking for some information.
Under current care, I have new note, and then under plan of care is my care plan, and under progress note is my assessment. Yeah.
Somebody have a question, or did somebody just unmute themselves?
Your mic is
I
on.
got muted too. So we're looking for ideas for the session. So if you have a future topic that you would like to include that in the chat or put that in your evaluation. So I think we'll open it up for questions. I saw some tackled the ones that were in the chat already, but if you have any questions that you'd like to bring here, feel free to unmute yourself and ask away.
Jennifer, it's Jill, and one of the questions I received was if you have a new team member or a new MDS nurse, where would you, what resources would you refer them to for onboarding or for training?
Well, I'm associated with ANAC, so that's the American Association of Nurse Assessment Coordinators. They have a very nice onboarding program. They have a 10-part MDS workshop. It's a recorded workshop that takes you through step by step all of the different MDS items. So that's a starting point. You know, certainly you could reach out to, you know, an agency like, you know, such as myself, or, you know, to provide training. It's hard because, especially if you're a standalone facility, if you don't have a corporate structure, if you don't have a home office, if you don't have MDS oversight, and it's hard to get that training in. And yeah, sure, you could read the book, but you know, it's 800 pages of content that you'd have to know and understand. So I think it's important for facilities to understand the importance of the MDS process and invest in your MDS team. If you want them to have good outcomes and good product, you need to give them good training and time to do it. And unfortunately, it does take a lot of time. It's hard information. I mean, it's usually when I train somebody, like I will do 2 full 8-hour days of just coding the MDS. And then we go into cause, and then we go into care plans, and then maybe we go into, you know, scheduling and PDPM, and there's just so much that is involved. I think it's important for upper management, administrators and directors and owners to understand and take value in that onboarding. And yeah, it's going to be a lot more training maybe than what a director of nurses or a charge nurse or a staff development might need, because there's just so much more involved. I mean, you know, like I said, I keep getting accused of being an MDS diva, not so much anymore, but I mean, MDS is pretty much the center of everything. Creating that care plan, having proper survey, quality measures, publicly reported, payment for Medicare. You know, some managed cares utilize that for the payment. Some states use it for Medicaid. Although I don't think any of the 4 of your states do. But it's important. It's just central. I mean, even having some sort of an understanding for the staff nurses to know what that is. Usually when I'm training brand new MDS coordinators who may be coming off the floor and we're charge nurses, and I go through the training and it's like a light bulb goes off and says, oh my God, I wish I had known this when I was on the floor, because that makes my documentation make so much more sense. And it, you know, the whole process makes so much more sense now that I know why we had to do it the way that we did it. And it just helps with buy-in. It's hard because it's not a lot of, there's not a lot of trainings out there, and some states do offer, like, MDS 101 type training. So, you can look into that. I apologize. I don't know what your individual states offer, but check with your state agencies and see if they have any kinds of training. And I'm always available. I'll Zoom you up. It's all good.
Thank you, Jennifer. All right, just a reminder for everyone to complete the evaluation in the chat box link. That will help you to get the CE credits for this and give us appropriate feedback for future trainings. Any other questions, or now's your chance to pick Jennifer's brain. So if you can think of anything else you'd like to ask, now's a great time.
And if you can't think of anything right now, I mean, I'm always available. I'm answering questions from people I've trained 10 years ago or worked with 10 years ago. So I like to make myself very available.
We appreciate that. Thank you. All right. Any last minute thoughts, Jennifer?
Just we appreciate all of the hard work that is going on. It's been a crazy year, and just try to keep on top of it. So, some of the things that have come out recently with the Medicare concerns, with PDPM payment concerns, they're starting to watch now that COVID is maybe not as crazy in our forefront. They're starting to look. OIG has a plan where they're starting to look at PDPM payments. If you read the proposed final rule, they think they've overpaid us by at least 5%, and they're going to start looking at ways to cut. So, just making sure your documentation supports the care and services you're providing. So your payment and quality measures are an accurate reflection of the great work that you do.
Okay. Well, I think we will close our session if there are no other questions or comments. We appreciate everyone joining today. We hope that this was helpful for you, that you've got some resources. Maybe now you'll just know what questions to ask. Maybe you didn't know what you didn't know beforehand. So we certainly appreciate you taking the time to jump on the call today, and be watching for future presentations from Jennifer.